Hi, this is Elliot Fishman, and welcome to our newest podcast. This is going to be on the CT detection and analysis of small bowel carcinoid tumors. I'm going to tell you everything you wanted to know about small bowel carcinoid tumors, and I'm going to show you lots of different examples so you'll never miss this diagnosis. Now, this cancer forms in the tissues of the small intestine. And when you talk about small bowel tumors, and I'll just mention, the most common is adenocarcinoma. Then we talk about sarcomas, like GIST tumors. We talk about carcinoid tumors, and we talk about lymphomas. And in the SEER data, which gives the magic numbers, 5-year survival in general is about 71%. You can see the estimated deaths of small bowel cancer in the U.S. is about 2,000, so it's one of the less common cancers, fortunately. You can see in terms of 5-year survival, it depends on when it's localized, patients do very well, and like most tumors, when it spreads to nodes, you do less well, and when it spreads distantly, you do even poorer. You can see it's number 20 in the top 20, roughly 14,000 new cases and a little over 2,000 deaths in the 2025 calendar year. So those are some of the magic numbers to look at. Now, when we talk about neuroendocrine tumors, they're typically slow growing and often remain asymptomatic until they're more advanced. Imaging modalities for detecting would include CT, and a lot of them are detected on CT scans, sometimes incidentally, but dedicated CT enterography or MR enterography. PET CT has become a very important role in looking at neuroendocrine tumors in general, including carcinoid tumors. Carcinoid tumors, when they go to the liver, are very vascular. CT is very good, but MR in a number of different articles is even more accurate. Now, most neuroendocrine tumors of the small bowel are sporadic. 5% or so have clinical syndromes associated with them. MEN, type 1, von Hippel-Lindau, neurofibromatosis, tuberous sclerosis. Neuroendocrine tumors with associated symptoms are often described as gastroenteropancreatic neuroendocrine tumors, with neuroendocrine tumors having been described in certain contexts as carcinoid or neuroendocrine tumors. And again, the NEN is probably the correct term. In terms of small bowel neuroendocrine tumors, peak age is 65 years, which is when most tumors seem to peak. There's no significant sex or race predilection. These tumors often grow slow and typically are hormonally inactive. The ones that are hormonally active are the ones that present earlier. And because they're not active, they can be large when they present, and often it's the metastasis that we will pick up. One of the things about them, patients with neuroendocrine tumors experience diagnostic delays with a mean reported time from first symptom to diagnosis of 52 months and nearly 12 healthcare visits. We often talk about small bowel tumors in general, from presentation to diagnosis being 2 years, but here we're talking over 4 years. A third of patients reported delays of at least 5 years. Specifically for small bowel neuroendocrine tumors, reported median symptom duration is 3.4 months, with some patients having over 5 years of symptoms. In terms of suspicion, this article by Nevin goes into the point that sometimes we'll pick things up on routine portal venous phase imaging, though of course neuroendocrine tumors arterial tends to be better, surely for the liver, but also to show the vascularity and desmoplastic reaction. Again, suspicion or looking for these tumors, looking carefully at the mesentery and bowel becomes very critical, because otherwise you can see a miss rate really at about 64%. High-quality evidence regarding the accuracy of CT or MR enterography is scant. We talk about sensitivity for CT in the 50% or greater range, with a specificity in the 90% range. But again, And similar numbers for MR. MR may have a higher prospective accuracy, but again, this in part is done with small numbers and small articles. So again, one of the challenges picking up these neuroendocrine tumors. Now, neuroendocrine tumors in general, whether it's a pancreatic neuroendocrine, whether it's a mediastinal, whether it's small bowel, are typically very bright on arterial phase imaging. They're hypervascular, and they wash out often very quickly. Their appearance can be nodular or polypoid or submucosal. There can be plaque-like mural thickening associated with them. There can be segmental submucosal spread. At times, carcinoid tumors can simulate Crohn's disease in the distal bowel, but usually the difference is when you have the mesenteric mass and it has a desmoplastic reaction, which you don't see with Crohn's disease, and also the vascularity of the mass is significantly higher. This desmoplastic reaction in small bowel mesentery can distort the small bowel, cause obstruction, or just irregularity of the mucosal folds. In terms of routine staging, it is CT. You'll get a chest and an abdomen and pelvis. Metastatic lymph nodes often are hypervascular. The primary mass is hypervascular. You don't want to use positive contrast in this examination. You want to use water. That's why CT enterography is so good. Mesenteric nodal metastasis often incite an intense fibrotic desmoplastic reaction with a starburst appearance, and may encase or occlude mesenteric vessels. And that's that desmoplastic reaction that's so important in terms of diagnosis. You can see thickening of the mesentery even in benign processes like sclerosing mesenteritis. And sclerosing mesenteritis also has calcification, as does carcinoid tumors, but there is a difference in appearance. The real desmoplastic reaction is something reserved for small bowel neuroendocrine tumors. We also talk about the liver. I mentioned before a touch that metastases are typically hypervascular on arterial phase imaging and quickly can become iso or hypodense on portal or delayed phase imaging. Occasionally the Mets can calcify, though that's fairly infrequent prior to treatment. Multiphase CT has sensitivity and specificity of 84 and 92% for detecting liver metastasis, even when they're very small. Peritoneal spread, coronal views become very helpful in that regard. And peritoneal metastasis can be seen in up to 20% of patients with small bowel neuroendocrine tumors. When patients do have bony metastasis, they're typically sclerotic in nature. When you look at the pathology in this article by Jasty, carcinoid tumors arise from the chromophone cells at the base of the crypts of Lieberkühn. It's most frequently in the distal ileum. But again, with carcinoid tumors, they can also be in the proximal bowel, in the duodenum, for example. But more common are going to be distal. We like to make the point that adenocarcinoma is more common in duodenum, and carcinoid is more common in the patient's ileum. But that's not always going to be the correct, and just is somewhere in between. Again, this idea about lesions enhancing. So with CT enterography, you can pick up small neuroendocrine tumors because they enhance, and when something enhances against a neutral contrast like water, it really stands out very nicely. We also talk about the mesenteric masses with carcinoid tumors, which are common. About 70% of the mesenteric masses will have calcification. As I mentioned, you can get a mesenteric mass with sclerosing mesenteritis as one example. You can get mesenteric masses which are treated lymphoma as another example. But again, the desmoplastic reaction is going to be very classic for carcinoid and not seen in things like sclerosing mesenteritis or in a patient with lymphoma, for example. Now, one of the things also, the term carcinoid and neuroendocrine, it's often used interchangeably, but remember, not all neuroendocrine tumors are carcinoids. I personally, when I think about pancreas, I talk about neuroendocrine tumors, And when I speak about small bowel, I mentioned carcinoid tumors. And again, the variation in terms of imaging, the appearances, hormone production, sites of metastasis will really depend on a number of things, including site of origin and how long it takes to make a specific diagnosis. Now, I mentioned most of the lesions will be distally in the ileum. Up to 8% occur in duodenum. They arise from either the gastrin-producing G cells or somatostatin-producing D cells. The majority of cases arise from G cells of the duodenum and result in duodenum gastrinomas, of which approximately 1/3 develop signs and symptoms of Zollinger-Ellison syndrome. Okay? When associated with MEN1, they can be multiple and located in the proximal duodenum. Carcinoid tumors arising from the D cells, not the G cells, are located in the periampullary region and can result in duodenal somatostenomas. So again, the location and the cell type has a very, very strong correlation, and that's important to remember. On imaging, duodenal carcinoids can have the appearance of intraluminal polyps or mural masses, and the vascular. Remember, it can be confusing. At times, a pancreatic mass, like a neuroendocrine tumor, can look like it. Also, things like GIST tumors just tend to be a little bit larger and grow exophytic. Carcinoids are typically intraluminal. But at times, particularly in that duodenal region, and I've shown many cases in conference, it can be very hard to separate. Tumors over 2 cm infiltrating the muscularis propria and with high mitotic activity are more prone to metastasis. However, even 1 centimeter tumors can have distal mets at time of diagnosis. Nodal and distal mets are uncommon, but are still seen in about 10% of cases. Now, in terms of the appearance of the tumor, small bowel carcinoids can be solitary or multifocal. You can have a dozen lesions. They can be mucosal or submucosal, polypoid most commonly, but it can be plaque-like, and usually under 2 centimeters. Key is dual phase imaging because the tumors may only be seen on arterial phase imaging, may become isodense on venous phase imaging and hard to see. Primary tumors typically under 3.5 centimeters. And again, metastasis to liver or nodes or mesentery can be substantially larger than the size of the patient's primary tumor. Now, one of the things also about these tumors, they secrete serotonin, which is what causes that desmoplastic reaction, where you see the tethering of bowel, you see the irregularity of the mesentery, you see the prominent vessels, whether it's coming typically off SMV or SMA, and that whole appearance, which can be challenging. Surgery is very difficult in these patients, often because of the infiltration, so it's something to be aware of. I mentioned calcification can be seen very commonly, small stippled or coarse dense or diffuse calcifications, but again, that does not give you the diagnosis, as sclerosing mesenteritis also has calcification in about 70% of cases. The differential diagnosis of carcinoid tumors in the mesentery include retractile mesenteritis, desmoid tumors, so the desmoids don't calcify, treated lymphoma, which will calcify, and metastasis, say ovary or colon, but then you have more of a carcinomatosis pattern. You'll see stuff in the mesentery, but typically findings in the omentum as well as in the pelvis. And occasionally a peritoneal mesothelioma can look similar, but again, not really. So if I'm thinking about carcinoid tumors, what am I looking for? I'm looking for the primary mass in bowel or the mesentery. Sometimes the mesenteric mass is easier to see because it's larger, and sometimes the primary mass is really small. We look for that desmoplastic reaction. We look for calcification of the mesenteric mass. And then, of course, we look carefully at the liver, particularly arterial phase, looking for vascular metastasis. And again, the two big mimickers are two of the ones I think about, and I've mentioned that already. Sclerosing mesenteritis, which can look almost identical, though the desmoplastic reaction is usually not as impressive as on carcinoid tumors, and of course lymphoma. But again, there's no desmoplastic reaction. It's mesenteric mass. Again, they can calcify if they've been treated. So examples: abdominal pain. This patient was given oral contrast. It's a little bit of an older scan, but I wanted to show it to you to make the point: only give water. When you have positive contrast, you can miss things. But if you look at this case, there's something going on, thickening with an ulceration in the second portion of duodenum. When you look at it at the coronal view in 3D, there's the mass under 2 centimeters, somewhat vascular, really nicely shown in the duodenal wall. The vessels look good. I don't see any liver lesions. This was a duodenal carcinoid tumor, under 2 centimeters in the duodenal wall. They can be very subtle, okay? And so volume rendering and MIP imaging can be very helpful, particularly on the early phase where you can pick up the vascularity of the lesion before the lesion washes out and maybe becomes isodense. So just a really nice example. Now another case, I asked you, do you see a duodenal mass? Well, here's a duodenum. What's this little enhancement right here? Kind of subtle, I guess. But there's something there a bit over 1 centimeter. When you look at the coronal view of that lesion, which is easy to walk by, you can see that it's a very flat lesion in the duodenum. There it is right there. What a great look on the coronal and on the volume rendered views. A 1 centimeter or 1.2 centimeter lesion, but it's flat. Look how easy that would be to miss surely on the axial images, easier to see on the coronal and volume rendering. And here's just a few more of that same case with volume rendering really showing you the vascularity of the lesion. This is not going to be a GIST tumor. It's not going to be ectopic pancreas. You could think of that. But this is going to be a duodenal carcinoid tumor. Another example. This patient has a duodenal carcinoid tumor. Here it is, 1 centimeter in the first portion of the duodenum. Look how small that lesion is. You can see some vessels nearby. It's a little bit of enhancement. When I do in the coronal view and I show it to you here, it's more obvious. Again, you could think of other things. It's not 100% a carcinoid tumor, but location in the bowel, very vascular, kind of a classic example. And here's just a few more views showing you that lesion. Just a very, very impressive case of a 1 centimeter duodenal carcinoid tumor. So again, look how carefully you need to look, and look how easy it is to miss. The importance of doing 3D reconstructions, multiplanar, and giving a high quality IV injection are really nicely shown by looking at this case. And again, here it is with the volume rendering showing you the lesion. And again, just a few more views. Even when the lesion washes out, which is the venous phase, we still can see the lesion. Again, the importance of good distension of the stomach and bowel by water makes this diagnosis very possible. Here it is with an arrow on the cinematic rendering. Again, cinematic rendering trying to accentuate intraluminal content in bowel, like this tumor. Again, very nicely shown in this example. You can see the celiac and SMA look good. I do not see evidence of a desmoplastic reaction. So here we're doing a good job of detecting the lesion, also planning for surgical resection, celiac, SMA, portal vein, SMV, everything looks good. And you can see again the textural changes. We speak about cinematic being really good for looking at textural changes, and here's just one example. Now, those were polypoid lesions. Lesions can actually be larger than that. And let's do this. Let's take a short break and come back and start really looking at a large number of carcinoid tumors as shown on CT. See you in a few minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.